Good evening. Welcome to another edition of DeBakey CV Live, the Aortic Talks. My name is Marvin Atkins, and I'm one of the cardiac and vascular surgeons here at Houston Methodist DeBakey Heart and Vascular Institute. This evening, I'm joined by an esteemed colleague, one of my favorite people in cardiac surgery, Dr. Karen Kim. She's currently an assistant professor of surgery and the associate program director of the fellowship at the University of Michigan. She's also a member of the aortic team and has a vast experience in aortic surgery. She did her training at the Massachusetts General Hospital, as well as the University of Pennsylvania, and did an aortic surgery fellowship with Dr. Bavaria there at UPenn. Karen, thank you so much for joining us this evening.
Thanks for having me, Marvin. Nice to see you again.
Great seeing you. To our audience out there today, when you're having questions for us, we'd love for you to join the conversation. There's a couple different ways that we have for you to join the talk. So tonight you can either join by the web. You can go to pollev.com and enter in the word DeBakey, and then you can respond with questions, or you can text us as well. You can text the word DeBakey, D-E-B-A-K-E-Y, to the telephone number 37607, and you can text us with your messages, and we'd be happy to take any questions that you have for us this evening. So tonight we're going to discuss type A dissection presenting with visceral malperfusion, which is really one of the most horrendous things that can happen to a human being afflicted with a type A dissection, is to have visceral malperfusion. It has the highest mortality rate. It's associated with other areas of malperfusion, and we'll talk about that a little bit. But we'd love to have Karen's experience and audience questions about patients that present with visceral malperfusion. So we'd like to do somewhat of a deep dive tonight on different options for managing these patients when they're presented with visceral malperfusion. Karen, do you have any opening thoughts on these patients when you see them?
No, you're absolutely right. This is a very difficult patient population to deal with, whether it's with type A dissection or type B dissection. There's a spectrum of mesenteric malperfusion syndrome. The best case scenario could be a mild lactate elevation and then an ileus that resolves pretty quickly. And then the worst, of course, is when you have small bowel necrosis and you end up with exploratory laparotomy, extensive bowel resection, open abdomen, multiple takebacks, reconnection or an ostomy, short gut syndrome, TPN dependence. I mean, like you said, so we're always trying to figure out a better way to help these patients survive, and not only survive but have a reasonable quality of life. And the work is ongoing.
Right. I guess one of the things that we should first discuss is the difference between radiographic malperfusion and malperfusion syndrome, that we can't confuse those two terms as being interchangeable. That sometimes you'll see on a CT scan when these patients, they all end up with axial imaging, they'll get a CT scan. That's a 1 second shot in time of what their true and their false lumen looks like. And so many times if you ran an intravascular ultrasound catheter up there, you would see that septum moving back and forth, but it just so happens to capture it on the time period that they are getting their CT scan that you'll see that the true lumen is very collapsed. And so you
That's
can
right.
see,
and
yeah, go ahead.
Oh no, I was going to say, like you said, snapshot. And also remember that when a patient gets a CT scan for diagnosis, they may not have been started on anti-impulse therapy yet. Right. So their blood pressure may be quite high, and that may promote blood flow through the false lumen and compress the true lumen. And then after the CT scan shows the diagnosis and they get started on a beta blocker,
Esmolol and
yes, then that can change the appearance of the flap, but you've already gotten the CT scan. So like you said, looking at the CT scan and diagnosing malperfusion from that without clinical correlation, you need to have both.
Right. We've all seen patients that have just a pancake true lumen all the way up and down, and their lactate's normal, they have no abdominal pain, but then we've also seen the converse. So you've got to put those two things together. So malperfusion syndrome and radiographic malperfusion, not the same thing. All right, so first thing we're going to do is anytime we discuss aortic dissection, it's always a good idea to go and look at IRAD. And so this is the IRAD data. This is kind of an older paper, JTCVS back in 2013, where they looked at, in the IRAD registry, all the 1,800 patients at that time that had been entered, what percentage of patients had visceral malperfusion. And so in this paper, fortunately, visceral malperfusion really only occurred in about 3.7%. In those patients, it was much more likely for the patients to be older, more likely for them to present with cerebral malperfusion and either coma, stroke, or spinal cord ischemia. More likely for those patients to have acute renal failure and limb ischemia. And so multiple papers have had, kind of numbers of areas of malperfusion. As that exponentially increases, the mortality exponentially increases. And so frequently these patients will have other areas of malperfusion seen. And when they looked at the mortality in these patients that had visceral malperfusion, 63.2% mortality versus in patients that did not have visceral malperfusion, a 23% overall mortality. And so it really does double at least your mortality rate when you present with visceral malperfusion. And so what we're talking about again is that you get flow from a large entry tear, whether it's in the ascending or, in this picture that they're showing here, a descending dissection, flow going into a large entry tear into the false lumen, which has a higher pressure, and then that causes collapse of the true lumen. And so typically your CT scan, it's usually that the true lumen is the smaller lumen of the two. And the usual typical pattern is that the celiac, SMA, and right renal artery come off of the true lumen. The left renal artery is typically off of the false, but you can have variations amongst all of those as well. So you really need to know all of the branches, where they come from, and also if you see dissection extending out into the branch vessels. And obviously the goal is not to see what you see there on the right-hand side of the screen, which is really what they call the peek and shriek. So basically you open somebody's abdomen and really all of their small intestine is dead, and that's not really compatible with life. So that's what we're trying to avoid. So when we talk about malperfusion, it's a good idea to talk about the two different types. So one is dynamic obstruction and one is static obstruction. And so dynamic obstruction means that you have the large septum is prolapsing over into the vessel origins during systole due to an increased pressure in the false lumen. And so you can see that where that septum is ball valving over and covering the origin of that branch vessel. The implications of that is that if you treat at the aortic level, meaning you either put a thoracic stent graft above, you do an endovascular fenestration where you equalize the pressures between the true and the false lumen, or in the old-fashioned days, an open fenestration where you cut that septum out and equalize the pressures between those two lumens. All of a sudden now that septum moves more midline away from the true lumen, ball valving over and covering those vessels, and you restore flow. The opposite of that is something called static obstruction, where not only is the problem at the aortic level, it's now also out into the branch vessels. And so the dissection goes out into those vessel branches that can lead to either significant narrowing or so bad that it can cause those vessels to thrombose. And in those situations, not only do you need to treat things at the aortic level, you also need to do something in those branch vessels, whether that's stenting or a bypass surgery to get flow out to those vessels, or if there's clot, sometimes you have to pull clot out of there. Any other thoughts, Karen?
No, when you nicely described the dynamic versus static, and sometimes you don't get a good sense of that on the CT scan. You can see thrombosis of the false lumen or the true lumen sometimes, but sometimes it's not obvious. So I think that IVUS examination and again, clinical correlation can be very helpful in figuring out what you're going to do.
Right. Many times these patients come with an inadequate CT scan. It's adequate enough to make the diagnosis of a type A dissection, but it's really inadequate for diagnosing how bad the visceral malperfusion is. So many of these patients will have chest pain. They'll get a PE CT scan of just the chest, and so it's kind of the wrong phase, and just of the chest doesn't extend all the way down, but it makes the diagnosis of a type A. Many times when those patients come to us with that type of imaging, we'll just go straight ahead and unless really the kidneys are not making any urine and they're really in acute renal failure, many times we'll go ahead and just repeat that imaging right away. It's such valuable information to know what you're getting into beforehand with a dissection. And so the next thing we'll kind of talk about is endovascular fenestration. And a lot of this work has been done at the University of Michigan, and one of the many reasons why we wanted to have you on tonight, Karen, to discuss things. Tell us a little bit about your understanding of kind of the history of endovascular fenestration at Michigan.
Well, the backstory is that Michigan is a very big state, and it also includes the Upper Peninsula. And so the distance required, much like Texas, the distance required to transport a patient or across the state is a lot, whether it's by ground or by air. And over 20 years or so ago, patients with aortic dissection would arrive to the University of Michigan in delayed fashion. So if they had malperfusion, they were outside, sometimes well outside, a 6 to 8 hour window where going straight to the operating room was feasible. And if they had bad malperfusion, whether it was gut or extremity, the patients would get operated on with an open repair, and they didn't do well, as you've mentioned in some of the published literature. So Mike Deeb and Dave Williams kind of thought this through and wondered, would the patients do better if you treated the malperfusion first and restore blood flow, let them get over the ischemia-reperfusion injury, and then get an open repair in a delayed fashion? So Dr. Williams is, one of the fathers and pioneers of this approach, and he takes the patients to, a hybrid OR. And using IVUS is able to, access the true lumen bilaterally in the femoral arteries, and then examine the true lumen, the false lumen, and he measures pressures and the pressure gradient between the aortic root and each of the visceral vessels as well as the extremities. And he can diagnose malperfusion with a significant gradient. He can assess where creating a re-entry tear would balance flow again. So in a type A dissection, you usually have your large primary entry tear, intimal tear in the ascending aorta, and the blood flows into the false lumen and doesn't kind of manage to flow back into the true lumen enough. There may be some fenestrations from intercostal arteries or the visceral vessels, but it's not enough. And so the idea behind a fenestration is to create a re-entry tear, whether it's in the descending thoracic aorta, infrarenal aorta, to rebalance flow. And Dr. Williams will sometimes use a natural fenestration or create one with a needle in the dissection septum of the descending thoracic aorta or the abdominal aorta, cross it, balloon that pathway through the septum to allow false lumen blood to get back into the true lumen, and then he will reassess the SMA, renal, and the iliac to see if the pressure gradient has been restored. After the fenestration, he does put a stent in the true lumen to keep it from collapsing, and then he will continue with branch vessel stenting if needed, if there's dissection that extends into the branch vessels, if there's thrombus, to make sure that there's no more gradient between the aortic root pressure and the visceral vessel pressure.
Have these always been done in a hybrid room, or have they been done in interventional radiology suite?
I guess when I say hybrid, I mean an OR that a place where you have fluoroscopy capability,
Okay.
And you could, you could do an open operation if you needed to. It's not necessarily the traditional hybrid OR, I guess, of, say, for example, that you're doing TAVR or hybrid aortic procedures. Sometimes if I really don't think that, if I think that the patient really is not going to need an operation that night, he'll do it mainly in a room that doesn't have OR capabilities. But, with mesenteric malperfusion, sometimes the patients will need an XLAP. So you do want to make sure that the patient can, or if it's lower extremity, fasciotomies or other vascular procedures. So it is nice to be in a room where you can do fluoroscopy and interventional procedures as well as some open surgery, even if it's not an open cardiac procedure with pump.
Gotcha. What's your usual timing for, whether, say, for instance, visceral malperfusion, they've got an elevated lactate, concerning exam, you go ahead and they complete visceral stenting, visceral fenestration, and then what's your timing of XLAP? Do you give time to wait? How do you judge that about whether you, right away open somebody's abdomen? Is there a time of waiting? And then the timing of the type A repair after that.
So these patients all get an acute care surgery consult. And I guess the time, sometimes it's obvious and sometimes it's not. I think they do tend to err knowing, how bad the mesenteric malperfusion can be. I think an XLAP with a look and then leaving the abdomen open and then taking the patient back in a day or so, depending on how the patient presented and how high their lactate was and kind of what the findings were during the interrogation of the aorta is not unreasonable. And so, I think that once they get that XLAP, they're not going to go to the OR for their type A right. until we're sure that their malperfusion syndrome is improving.
Gotcha. Okay. All right. What's the typical kind of delay in most patients, do you think, between visceral fenestration and then going to the OR for the type A repair? In the absence of pericardial effusion, impending rupture, those types of things.
If a patient has a lactate elevation that resolves quickly, they didn't need any bowel resection, or even an exploratory laparotomy. Once the lactate is starting to trend down, and it doesn't even have to normalize completely, but once it's starting to trend down and you see that the patient is kind of turning the corner, you can take the patient to the operating room, and that could be 1 or 2 days, as early as 1 or 2 days. It's probably not immediately because you do want to trend the lactate for a couple of values to see if it's going up or coming down. But I think our average time to OR in the setting of kind of mild to moderate mesenteric malperfusion may be 2 to 4 days. If it's extensive with bowel resection, open abdomen, repeat exploration, then it can be longer. So it could be, 5 to 7 days, and then and depending even more. But I would say the mild to moderate ones could go to the OR in 2 to 4 days.
Okay, great. So let me move on to the next set of slides here. So again, the endovascular fenestration, as Dr. Kim was describing, ballooning that septum, creating a septostomy, and then putting usually they use a wall stent in the true lumen, is that correct?
Yes.
Yeah, so it's a 16 millimeter balloon and then a 16 or an 18 millimeter wall stent to stent open that true lumen to make sure that there's adequate perfusion through there. And the fenestrations of the wall stent are large enough that you can cannulate the side branches, and if you needed to stent something, you could. And then tell us a little bit about TEVAR. Are any of the folks at Michigan using TEVAR in this setting or not?
So because we have our talented vascular interventional radiology colleagues, for type A dissection with malperfusion, we don't do a TEVAR to relieve the malperfusion. We go forward with fenestration. If the patient has a type B dissection,
and you could seal the entry tear.
Sorry?
And if you could seal the entry tear in a type B dissection?
Oh, yeah. So I take a look at the anatomy to see what the proximal landing zone looks like. Sometimes the dissection goes right up to the subclavian, as does the intimal tear. And so if you need to cover the left subclavian, and that would involve revascularization, sometimes it's just faster to do at our institution to do the fenestration to relieve the malperfusion, and then to deal later with the any aneurysmal degeneration of the proximal descending from the intimal tear. So if there's a really nice landing zone proximally in a type B dissection, though, then a TEVAR is very reasonable. And then after that, looking at the visceral vessels and addressing any malperfusion with stenting and or infrarenal fenestration or aortoiliac stenting.
Gotcha. At Michigan, does cardiac surgery or vascular surgery participate in the fenestration procedures, or what's the role of the surgical teams during the fenestrations?
So I and the vascular interventional radiologist evaluate the patient and review the imaging. If the patient gets fenestration, the vascular interventional radiologists do that procedure. Then the patients are admitted to the cardiovascular ICU, and then I'm the primary attending
Gotcha.
with the cardiac surgery service, and then I would perform open type A repair. If it's a TEVAR, then both cardiac surgery and vascular interventional radiology do those procedures together.
Gotcha. Karen, we're going to take a quick break. We've got a question here for us. The first question for you, I'll throw it your way. So the audience is asking, in these patients, can the usual aggressive lowering of blood pressure in aortic dissection worsen intestinal ischemia? If so, can we tolerate higher blood pressure targets in this population? Great question.
I think very paradoxically, one would think that higher blood pressure would promote better perfusion. But the physiology in dissection is such that a lower blood pressure will better promote true lumen flow. So by lowering the systolic blood pressure to 90 to 110 and or 90 to 120, you're trying to redirect blood flow rather than going across that intimal tear, staying in the true lumen, and that will help perfusion of any of your branch vessels that come off of the true lumen. So having a higher blood pressure of 140, 150, 160 in a type A dissection with visceral malperfusion, I don't think that would actually help your visceral malperfusion.
Gotcha. Okay, great. So next, go back in history here. So again, there's another option for fenestration, the open surgical fenestration. And so this is, I think I took this out of Mel Williams' textbook from Johns Hopkins, of where they had patients that presented with dissection. This is before the endovascular era. And so they would take these patients and then either of the thoracoabdominal aorta or infrarenal aorta, essentially open up the aorta, divide the septum there, cut out the septum, and then take two large felt strips or a tube graft, as you can see there on the right-hand side of the screen, and basically now create an open surgical fenestration. And this obviously works very well. They usually will try, if the patient has an aneurysm, they'll try and take a tube and mold the aorta, suture it back over as a smaller diameter. And there's some data from the Hopkins group over many years, decades, where they followed some of these patients that had open surgical fenestrations that their aorta did not dilate out. Have you done many open surgical fenestrations or had much experience with that? It's relatively rare these days that anybody does that.
That's right.
So I
would say yikes to that.
Yeah. So I did I did it once in practice, and so I have to show slides on that. So here's a patient that had a visceral segment malperfusion that I was trying to fenestrate endovascularly and just could not. And so ultimately I clamped above her renal arteries there, made an incision across the renals down onto the infrarenal aorta, and was able to tack the intima back into her renals to put her static obstruction of her left renal artery back together, and then just ran a felt strip over the top there. So that's my one and only surgical fenestration. But it seemed to work.
Wow.
She was making urine on the table as soon as we opened the clamp. So. All right,
That's
Karen,
amazing.
I've got a case for you here. So this is a 57-year-old female who actually only presented here at Methodist probably about 3 weeks ago with a really bad problem. So her past history is significant for tobacco abuse. She was smoking about 2 packs a day. She's morbidly obese, hypertensive. She's insulin-dependent diabetic, and she presented to an outside hospital with symptoms of epigastric pain of acute onset. They found that she had an acute abdomen. She was in acute renal failure with a creatinine of around 3 and marginal urine output. And on exam, when the general surgeon saw her, they were very concerned that she had intestinal ischemia. And so she was urgently taken to the operating room where she underwent an exploratory laparotomy and then ultimately had about 120 centimeters of her jejunum taken out. So large small bowel resection. The operative notes that we saw really don't mention anything about pulses, the usual type of stuff. And then she was placed on TPN and had a really rocky post-operative course, but her kidney function slowly kind of improved. And it got to the point about a week later, they thought, well, now it feels like she's got some diminished pulses in her left lower extremity. Let's go ahead and let's get a CT scan and see what's going on. And so they actually got a CT and, of course, now make the diagnosis of a type A dissection, which was probably her original problem to begin with. And a very diminished collapsed true lumen and diminished flow going down the left leg. Surprisingly, despite that, at this point her lactate was normal, her creatinine had trended down, which was the reason why they were able to get the contrast CAT scan. And so not all patients read the book. They never present how you would expect them to, but this is the patient that we then received and transferred to our hospital. And so here is her outside CT scan. And so it looks like she's got a dissection going into the left common carotid there. There's her type A dissection extending all the way down to the root. She has no pericardial effusion. And you see just a pancake true lumen as we come now into the visceral segment here. And so it's really hard to see the true lumen whatsoever all the way through there. Left kidney came off of the false, and then that was the outside CT scan that we got. I think she may have had some chest pain episode, and so that was actually a PE CT scan that they got. So she got transferred here, and at that point we repeated the CAT scan. And fortunately, nothing had changed. Maybe a little aspiration of her left lower lobe there. Again, a pancake true lumen, but flow still in the celiac, the SMA, and the renals. And I actually didn't record the rest of this, but it goes all the way down. The dissection extends down into her left common iliac artery, and there's very limited perfusion there. So at this point, we got a duplex ultrasound of her kidneys, and you can see the velocities there, and her renal arteries are really low in the 20 peak systolic velocities in the 20 centimeters per second. So very low velocities in her kidneys on both sides. So again, concern for malperfusion. And despite her urine output was kind of marginal, her creatinine was in the low ones. Although it had been higher earlier in the course of things. So Karen, back to you. All right, what to do in this patient? At this point, she's about a week out. She's had an X-lap. She's got very bad COPD, active smoker up until the time of her dissection. Initially renal failure, now it seems to be somewhat resolved. She just got another dye load. and she's hemodynamically stable, not on any pressors. Echo shows no severe aortic insufficiency, aortic valve insufficiency, and no pericardial effusion. So what to do with this lady? I put out four options here.
In my mind, this patient is a survivor.
Correct.
This patient, has gone a week out from the type A dissection and has not died from rupture, coronary malperfusion, or severe AI with heart failure. Looking at her CT scan, it looks like the diameter of the ascending aorta may be slightly enlarged, but it's not a large aneurysm. Right. The intimal tear kind of was proximal near the STJ, and it looked like there was reasonable flow in both the true and the false lumen. No partial thrombosis of the false lumen that would suggest that it was pressurized, and like you said, no hemopericardium or other signs that there might be contained rupture. So I think that dealing with her organ perfusion is more important than taking her to the operating room to deal with her type A dissection, since she doesn't have any complications in the chest of the type A dissection. So malperfusion first, or dealing with the malperfusion first, even though she has a normal lactate and she has had bowel resected. I think, like you pointed out, the true lumen is obliterated, so there still is probably not ideal or adequate blood flow to the mesenteric system, and then you have the renals and then the extremity or the iliac. So at Michigan, we would go ahead with fenestration and then manage the malperfusion first.
Gotcha. So the four options that are up here. So one, proceed with type A dissection repair, plus minus an antegrade TEVAR at the time to open up the true lumen. Again, you mentioned your option would be number 2, endovascular fenestration, plus minus visceral vessel stenting, and then a delayed type A dissection repair. One of the things we didn't talk about was kind of one of the older ways of fixing this is where patients would go for an ax-fem bypass, where essentially axillary artery graft tunneled along the chest wall, brought down from one groin, brought over to the other, relieves the malperfusion of the lower extremity, and with that backflow, many times it'll also increase the flow in the true lumen, and will help out with the visceral malperfusion there as well. But that's one of the older ways of fixing this. And then the last one I put up here was bare metal stenting of the thoracoabdominal aorta, followed by type A dissection repair. So one of the things that has happened in the world of type B dissection repair is the petticoat procedure utilizing the Cook dissection device, and essentially that's either a 36 millimeter or 46 millimeter bare metal stent that is placed in the true lumen, which can be combined with a TX2 or really any proximal thoracic stent graft device. But one option here, which we chose, which was to put just the bare metal stent throughout the thoracoabdominal aorta, and we'll kind of go into that a little bit. We'll go to this, and then I think we've got another question up for us. So one of the things we're able to do here is we do a spin beforehand. We take the patient's CT scan, and we're able to mark the origins of all of the branch vessels there on the screen. So you can see the circles there represent the CT image overlay of the celiac, the SMA, the renals, the takeoff of the IMA, and then the aortic bifurcation and the hypogastric bifurcations there on both sides. You can see we've got the IVUS catheter there. And so we're measuring, looking at the true lumen all the way up and down, and seeing that it's just really just pancaked, closed all the way down. When we initially came in on the right side, the wire passed up, and then it went up, and it seemed like it was getting hung up in kind of the mid aorta at the level of the diaphragm, and so I ran the IVUS catheter up. You could see we were in the true lumen, and then I actually had gone through a fenestration into the false lumen and could easily see that with IVUS, and so we pulled back down into the true lumen, rewired, took an angle glide catheter, turned the wire the opposite direction, and then went back up. And so one of the important things during these procedures, when you're thinking about stenting anything, you absolutely have to be in the true lumen, and so IVUS is essential during these dissection procedures to be able to confirm that you're in the true lumen.
Completely agree.
And so on her CT scan, it really looked like that from the level of the subclavian to the upper third of the descending thoracic aorta, really the true lumen there was not compressed that much. We could also see that when we ran our IVUS up there as well. And so by putting a bare metal stent, I didn't want to get anywhere near the turn. I wanted it to really be in a relatively straight segment of the aorta. And I really didn't want to try and even get my wires over into the ascending with that fragile dissected ascending aorta there. I didn't want to mess with her entry tear or have something stupid happen from the wires there in the ascending. So I really just kept the wire below the level of the left subclavian. I knew I didn't need to stent all the way up there. And so we then took 2 pieces of the fenestrated, of the dissection device, which is a 36 millimeter we used in her case. We started off down below, just parking it just above the infrarenal aorta, deploying it, and then we took a second piece up a little bit higher into the mid thoracic aorta, and then ran our IVUS catheter up. And so this should be the device getting deployed here. The older I get, it's harder for me to see. Is that deploying a device there, Karen?
I think I see something there, so yes.
And then here's that second piece that we're putting up a little bit higher. Again, I really didn't want to get my wire or the nose cone or anywhere near the turn of the proximal descending thoracic aorta there. We'll kind of skip forward.
So we don't place the petticoat device here at Michigan, although I have read about it and know what it is. How do you consider, what are the sizing considerations for picking the device size?
Yeah, so it really only comes in 2 devices size-wise. So it comes in a 36 millimeter or a 46 millimeter. And the cage, it is really flimsy. And so that's actually a good thing. It never really expands to 36. You would never ever balloon it. We never balloon during dissection cases with TEVAR or with the petticoat device. And so it's very soft and flimsy. You're not going to create new sign or new entry tears. And it really has enough radial force that it's going to push that true lumen open enough. I actually did not measure what final diameter. I guess I probably need to do that, is go back and look at the CT scan and see exactly how large the true lumen became, which we'll see on the CT scan here. But it definitely wasn't 36 millimeters, that's for sure. One of the other things that I did is I wanted to make sure that right renal artery, I could never really see the origin of that, and there was a question of whether that had a static dissection going out into the renal origin as well. And so I was able to easily wire the right renal artery through these big interstices of this stent. And then we ran a smaller intravascular ultrasound catheter, an 014 Eagle Eye catheter, over a Platinum Plus small wire out, and it looked like that the renal was now filling. And she had significant improvement in her renal function and filling over the next several days. We also took a self-expanding stent down the left common iliac, which was dissected and had a diminished pulse, and her pulses came back as soon as we put that in there as well. So again, in this situation, pre-curved Lunderquist wire was not brought into the ascending aorta. I really kept it in the descending. Again, intraoperative TEE was to confirm that there was no worsening pericardial effusion, worsening AI, or something that had changed when we changed the flow pattern and the dynamics once we stented her dissection. Again, we used IVUS. We really didn't want to use contrast. I remember one of the things that Richard Cambria used to hammer on us all the time at MGH in dissections was that angiography can be a trap. And so what he meant by that was if you take a angiographic catheter and you set it at 900 psi and you put it into the true lumen and you then do your power injection with your power injector, you will push that true lumen open. You'll tell yourself picture-wise, oh, that looks great. rate it's filling, but if you ran the IVUS catheter up there, you'd see as soon as that pressure bolus of contrast went away, now all of a sudden the true lumen is collapsed again. And so angiography can be a trap in these situations. So, for the most part, especially in this situation, because we were so worried about her renal function, I actually didn't do use any contrast, and just did everything with IVUS to look at the vessels and make sure that the lumens were open. And again, I said we put the common iliac stent in there, which all of a sudden she now had pulses in her left lower extremity. I did measure pressures from her right radial to the femoral sheaths that we had. Again, and the pressures normalized between the two, so I knew that we had significantly improved the malperfusion. The unfortunate thing is when she went to sleep, I think she had a very significant aspiration. She had this small bowel resection, still had an ileus. I'm not sure if her NG2 was not functioning well or what, but essentially when she went to the operating room, she unfortunately aspirated. And so at the conclusion of the case, despite having relieved her malperfusion, we were having significant hypoxia issues. And ultimately she ended up going back up to the ICU and had a very rocky postoperative course from aspiration, developed ARDS from this, and it was about another week to 10 days before we were able to extubate her and get her better. But her kidneys improved, and she was able to get off CRT, and her renal function improved. So at this point, she's now almost 3 weeks out from this initial presentation to the outside hospital. She's had an XLAP. She just had aspiration pneumonia of gastric contents and bad ARDS. And so at this point, she was extubated, she was talking, but she was really frail at this point, probably too frail to undergo a type A dissection repair. And so we actually have her in our in-hospital rehab where she's close, and they're working with her. And I looked at the notes from today, and she's up walking around. And so I think she's slowly recovering and getting better. And I'm hopeful that we'll be able to bring her back relatively soon and get this type A dissection repair fixed. I do have a post-op. Oh, go ahead, Karen.
I was going to say that now she's in a more than 2 weeks out, she's in a subacute phase, right? She's not in an acute phase anymore. She's continued to survive miraculously the complications of her type A dissection. She doesn't have severe AI or significant AI. The flow in her ascending aorta is stable, and so there hasn't been a coronary malperfusion. And so there is still a risk of rupture, but depending on the diameter of the ascending aorta, the further you get out, the more it's about the ascending aorta and risk of rupture. I mean, I agree that she should undergo type A dissection repair when she can reasonably survive that operation, because you're talking about cardiopulmonary bypass, edema of her intestines again, as well as kind of her whole body having to recover from hypothermic circulatory arrest. So yeah, it doesn't sound like she's yet able to get through that.
Correct. All right, let me show you the post-op CT scan. And this is obtained now probably about 3 weeks out after her original presentation, and her ascending aorta really hasn't changed in size at all, which was very reassuring to us that we were doing the right thing, kind of sitting on things. And so you can see that dissection stent graft, the true lumen is really pushed open. Yeah, I need to go back and measure the diameter of that and see exactly how big it got, but clearly, obviously not 36 millimeters. And when you feel that stent, it's pretty flimsy, but adequate enough.
You can see how the true lumen is circular.
Right.
It's not a, well, first of all, it's not obliterated, but it's not even a crescent. It's circular.
Right.
So that's great.
All right, we've got another question from the audience. So they said, besides fenestration in the mesenteric arteries, can fenestration upstream of the celiac trunk help to obtain a better mesenteric flow? And that's typically what's done. Your fenestration procedures are done just several centimeters above the celiac artery, is my understanding, correct? Yeah. So
if it's mesenteric malperfusion, if it's SMA, then the fenestration will need to be done proximal to that. If it's lower extremity malperfusion, depending on the flow between the true and the false lumen and the fenestration, you may only need an infrarenal fenestration to be able to balance flow and reestablish true lumen flow. But in mesenteric, it would be supraceliac with a wall stent, plus or minus visceral stenting.
Gotcha. Okay. So briefly, I just wanted to kind of mention the University of Michigan experience. Now, again, this is type B dissection and malperfusion, not necessarily what we're totally talking about today, but similar malperfusion of the visceral segment here, patients presenting acutely. And again, this is a patient that they have in their paper, and this is a great paper describing their technique, describing how visceral fenestration is done at Michigan. And again, balloon fenestration which is created 2 to 4 centimeters above the celiac using a 16 millimeter balloon, and then putting a 16 to 18 millimeter wall stent in the true lumen if necessary, if it seems that the true lumen is still collapsed by IVUS, or measuring pressure gradients. And that's something I routinely have not done, is taking end hole catheters and measuring gradients across the vessels. I believe a 15 millimeter gradient is what they consider significant, and where they got that from, I guess, is patients that have coarctation, what you consider a significant coarctation. And so a gradient of 15 means that you need to do something else between the aortic root and the abdominal aorta, and then stent these branch vessels as needed. Here they've got a stent going into the SMA. And
it's really nice how Dr. Williams does measure the gradient between the root and the visceral vessels, because you want to make sure that you address all the malperfusion, but just stenting all of the visceral vessels comes with possible complications as well. So if you it may be possible that just doing the supraceliac fenestration resolves all of the malperfusion, so then you don't have to do any visceral stenting. So it's really a nice directed therapy.
Does Dr. Williams have one or more kind of proteges that are picking visceral fenestration up?
Yes, he does. Yep, Minhaj Kaja, who went to UVA sadly, but hopefully he'll come back. Charlena Marco and Bill Schur also are part of the team.
So he's not on call Q1 for visceral malperfusion, so that's good.
Well, I tell you what, even still, Dr. Williams still does aortic call when he's in town, and so only when he's not in town.
Gotcha.
But otherwise, he's there at all. It's really a passion for him.
Oh, of course.
Aortic dissection, and he wants to help any patient he can who has malperfusion. It's really amazing.
Yeah, that's great. He's really advanced the field in our understanding of malperfusion. So the outcomes in type B dissection, at least there at Michigan, you can see some of the other procedures that had to be performed, and relief of malperfusion happens in the vast majority of patients. And mortality is relatively low. I think in-hospital mortality 7% in the type B dissection patients with malperfusion, which is awesome.
Yeah, it's definitely higher in type A dissection with mesenteric malperfusion syndrome. I think in all comers, mortality can be as high as 40%. But we found that rather than the patients dying of rupture, the ones who didn't make it to type A repair, they died of their malperfusion syndrome and complications of their mesenteric ischemia. The ones who were able to get through the malperfusion syndrome and then undergo surgery did well, and their long-term survival was similar to patients who just underwent type A repair. So that really is the kind of underpinning of our strategy.
Gotcha. All right. So next, I'd like to talk a little bit about the Emory experience. So this is a paper from Brad Leschnauer, Ed Chen, and the group at Emory. Really looking at a thoracic endovascular aortic repair first strategy for these patients with type A aortic dissection and mesenteric malperfusion. And so in this paper, they went back and they looked at all of their patients, I think from 2003 through 2017, that presented to Emory with type A aortic dissection. They pulled out 34 patients that presented with visceral malperfusion that had an elevated lactate and really had mesenteric ischemia. And then they looked at the different strategies that were used over this time period and how the patients did. And so, the original strategy is these patients would just go for a type A dissection repair. They get an XLAP at the end of the procedure, and unfortunately, sometimes you would find what I showed on that earlier slide is the small bowel all dead, and everything you've just done for the last several hours repairing their type A dissection was for naught. Another option was using an axe bifem graft that we talked about, then also doing type A dissection repair with an antegrade TEVAR, which is something that happened in the later course of the paper here in their study. And then the last has been this kind of TEVAR-first approach, followed by delayed type A dissection repair. And so 34 patients, I think it was 13 patients had this TEVAR-first strategy, 3 patients had the axe bifem, and then a smattering of the other patients had dissection repair with XLAP and antegrade TEVAR. And what they looked at is they looked at the results, and we can see here the mortality rate there at the bottom. So for patients that had XLAP, following that, it was almost a 70% mortality rate. All 3 of the patients that got an axe bifem actually survived. The patients that had type A repair with an antegrade TEVAR, I think it was 2/3 of those patients did not survive. And then of the patients that had this TEVAR-first strategy, the mortality rate was somewhere around 30%. So they think they've kind of cut their mortality rate in half, from around 60-something% down to 30% by taking patients and doing this TEVAR-first strategy. And so again, this is kind of their algorithm, so we can kind of go through that. So they make the diagnosis of somebody with malperfusion. So if the patient's hemodynamically stable and they don't have a pericardial effusion, they don't have any ongoing chest pain, no signs of rupture, then they will get TEVAR with angiographic evidence of iliac and SMA perfusion. They'll go back to the ICU, get resuscitated during this reperfusion phase, and hopefully resolution of their abdominal pain and lactic acidosis, and then they'll get a delayed proximal aortic replacement within 24 to 48 hours, depending upon the patient's hemodynamic status. If the patient's hemodynamically unstable or if there's signs of rupture, then they'll get emergent proximal aortic replacement with a pre-cardiopulmonary bypass axe bifemoral bypass plus minus antegrade TEVAR at the time of the procedure. And so that's how they handle the unstable patients. If the patient has persistent abdominal pain or lactic acidosis after this TEVAR-first strategy, then they will definitely get exploratory laparotomy, and they'll hold off on completing their type A dissection repair. And so really it's almost a strategy similar to what you guys are doing in terms of treating their visceral malperfusion and making sure the patients recover before they proceed on with their type A dissection repair.
And similarly, if a patient is unstable, has hemopericardium, severe AI, etc., then we also proceed with our open repair, and then with various cannulation strategies, direct aortic or axillary, and we will commonly do an antegrade TEVAR to try to treat any large reentry tears in the proximal descending, and then also expand the true lumen as much as possible. Femoral arterial lines on one or both sides help determine whether you still have malperfusion distally after your operation. Right. And if that's the case, then I will have Dr. Williams interrogate the aorta and then resolve the malperfusion with fenestration and stenting.
Yeah. I guess I've been here at Methodist now for about 3 years, and this TEVAR-first strategy has kind of been what we've done. And then recently, again, we had this one case that I showed as kind of the first one where we just used that dissection stent in this setting rather than a TEVAR. But so far, seems to work out. I'd like to thank Dr. Karen Kim so much this evening. Thank you so much for joining us. Looks like I have one more question for you, though. They snuck that in here in the last second. So is there a level of lactate or a scanographic aspect of the intestines that indicates that it's too late to treat malperfusion? So how high of a lactate, how unstable of a patient is somebody who's just too far gone?
So I don't think there's a cutoff at which you would not try fenestration, but my colleague, Dr. Bo Yang, found that lactate of 6 or greater was significantly associated with a higher mortality. So you know that when it's gotten to 6 or higher, that it's advanced, but that doesn't mean that they don't have, that they can't potentially survive with intervention.
And that's the great part of these other strategies of either fenestration or TEVAR-first. It allows you at least to temporize these patients and see which direction they're going to go, if they're going to recover and be able to tolerate a bypass run, circ arrest, type A dissection repair. So kind of a middle ground to at least see which direction that they're going to go. All right. One other question. They're piling in here in our last 2 minutes here, Karen. So what are what's the reasonable time to evaluate the success or failure of visceral malperfusion treatment before treating the ascending aorta?
I mean, I would say at least 6 hours to have the patient go to the ICU, and again we're talking about a stable patient without concern for ascending rupture or significant valvular dysfunction. So I would get the patient to the ICU, trend their labs for at least 1 or 2 lactate levels, and again in patients with mild malperfusion syndrome, where the lactate really just kind of starts going down, I could take that patient to the OR within 6 to 12 hours. So I wouldn't even necessarily wait several days. But so that would be maybe the earliest, and that would be after a couple lactate levels.
Karen, do you tend to repeat the echo or anything like that when they get back to the ICU? If they go down to radiology and they've had their fenestration and they get back up, are you repeating echoes and rechecking to see what's going on proximally?
We ask cardiac anesthesia to do a TEE during the procedure.
Gotcha.
And so they assess for AI, they assess for cardiac dysfunction. They're looking for an effusion. The patients get some heparin during the procedure, followed by protamine. But if they develop a new effusion, then that could be significant information. So they do a TEE, and then once they and at the end of the procedure, they just make sure everything's okay, and then the patient goes to the ICU. So I don't necessarily get a transthoracic echo there, and it's more about kind of making sure, as long as there aren't any new signs in the ICU that something has happened, EKG changes, hypotension, etc. Sure. So after assessing for clinical improvement, they would go, and when I feel that they're ready, I would take them back to the operating room, and then they would get an intraoperative TEE at that point, again for the operation, for the type A repair.
Great. Karen, I'd like to thank you so much for joining us this evening and enlightening myself and our audience with all the experience that you've had there at Michigan, and you're up-and-coming star in the world of aortic surgery, and we appreciate your time.
Well, I definitely, it's a huge team effort at Michigan, and we couldn't do this. Certainly, it's not just about cardiac surgery. We have our vascular interventional radiologists, vascular surgery colleagues, acute care surgery colleagues, ICU, the OR, our APs, everybody. And so it's really a big institutional effort that has, I think, helped a lot of patients. But Thank you so much for inviting me. It's been very fun.
All right. Excellent. Thank you guys very much. Thanks for joining us this evening. Bye-bye.